Hey, what's up, Charlotte family? Hope you guys are doing good. Welcome to another week of our Hospice 101 lives. If this is the first time you're hopping on, welcome. We've been over the last couple months walking families through what is hospice, what does it entail, because there's just a lot of confusion when it comes to hospice as a whole. And what we wanted to do is just walk families through what hospice is and what it isn't, utilizing and using stories of our patients that we've taken care of over the last 23 years, reframing their story specifically, and helping you to walk into their shoes and see if this is something that can relate to you, a loved one, or someone that you may know that may be on the journey of home health all the way to hospice care. And so this month is Stroke Awareness Month. What we've been doing is highlighting specific diagnoses every month, and so we wanted to talk about CVA and stroke this month. And in this journey together, we're going to talk about a patient who had a stroke, then also went to home health, did pretty good on home health, but continued to decline all the way through when he qualified for hospice care services, and walk you through that whole journey. And so if you're watching this, it just recently is Nurses Week. So if you're a nurse, we just want to honor you and thank you for all you've done to take care of patients day in and day out. And then if you're a nurse and a mom, you're like a double caregiver. So we just want to say thank you for Mother's Day as we celebrated recently, and then also Nurses Week. So looking forward to chatting and enjoying this Hospice 101 conversation as we talk about Mr. Danny Reeves. So we wanted to also highlight a few stats when it comes to hospice care. There's about 1.8 million people, close to 2 million people on hospice annually, which is a lot of people. But the reality of it is that a lot of families, when hospice is going to start, it's like at the very, very last minute. And so if you look at the statistics here, about 18 to 21 days are served on average on hospice, when really it's 6 months, and some patients live longer than 6 months if they continue to qualify and continue to meet the clinical measures that are needed for hospice services. But that's a lot of benefit that isn't utilized or used, because we hear this a lot, is that families will say, man, I wish I would have known about hospice a little bit sooner. I was just so scared. I didn't know what it entailed. And so what we were doing here is just kind of walking families through about what hospice is, and educating you as you're watching as well. So this week's story, is about Mr. Danny. So we talked about this. We're doing these Hospice 101s where we're talking about a patient that we've taken care of, but reframing it for HIPAA purposes. So we're going to talk about Coach Danny. Yeah, he was a fish in water, basically. So Coach Danny loved the water. As a former competitive swimmer, also a high school coach, and he was known for his loud whistles in the morning. And everyone knew that, hey, when Coach Danny was ready, we all had to get ready. We all had to get ready to swim and to work hard. And so he wasn't just about swimming. He was also about pouring into kids and the next generation to understand discipline and work ethic, which is so valuable now. But 7 years ago, his wife passed away suddenly, and he was only left to take care of him and his daughter. And so his daughter is older now, of course, and lived out of state for work, moved out of state for work. And what happened was pretty sad, is that randomly Coach Danny had a stroke in his 60s. And one moment he was going from being a coach, a retired coach at that time, and kind of volunteering at the high school now, not working, doing everything, to now in a hospital bed having a stroke. And then after the hospital incident, he had to go to a rehab for 2 to 3 weeks to get that strength, to get this mobility in his right side. Speech was slurred, so he had PT, he had OT at the rehab, he had speech therapy at the rehab. All these things he had to work. He had to almost really put all those things that he learned in his life when it comes to discipline and work ethic. He had to now retrain his whole body, because of that stroke, which was a really tough time, especially because his daughter was out of town for work, but she would come back and forth while he was in the rehab as well. And so, Coach, that confidence that he learned over the years, he was able to bounce back, which is wonderful. And after he went into the rehab, he was discharged, and he went to actually a group home, because being going from independent now to like actually needing help, He needed home health, and that's where we met him at home health at home. So he was able to get a nurse in there to coordinate with the group home. He was also able to get physical therapy, speech therapy as well, and we were with him for a while to kind of help encourage him, walk him through several bouts of therapy, several episodes. So home health is about 60 days stints, and after each 60-day stint, if the goals aren't met, then he continued to recertify until he was able to bounce back and do some great things, and at least to get back to his the things that he tried to do. He couldn't do all the way he used to do in terms of like volunteering and swimming, and but just this quality of life, which was important for home health. But unfortunately, a year or so after, he had a few setbacks. He had some infections. He had severe muscle weakness, and he went back and forth to the hospital. Hospital left him tired, and it was getting worse. Home health was helping for a while to maintain that quality of life, but it got to the point where now his condition was getting a little bit worse, and it was kind of difficult because at that time his daughter Lauren was out of town, and they're just FaceTiming, the doctors in there, and Coach Danny was like, "Hey, I've done my best. I just can't take this anymore. I'm wiped." And the doctor was saying, it may be time to consider hospice. He was losing weight. He wasn't eating as much anymore. A lot of the things that he was doing, he just couldn't do it anymore. And Lauren is just like stuck because she's like, "Whoa, like what does that mean? I'm out of state. Hospice. I've never even heard of the word hospice, right? Because her mom passed away, unfortunately, in a car accident. And so these are the situations that we see a lot. And so if you're watching this for the first time, welcome. What we're doing is we're educating families on what hospice is, what a hospice 101 is, and what it means to walk a family through. So we're utilizing a story that we've taken care of a patient and kind of reframing the story for HIPAA purposes, and allowing you to see that situation and see if that's something that resonates with you or loved one or someone that you may know. And we're going to walk you guys through now what is hospice. So now Lauren has heard the news about what is hospice, what does it entail. And Danny her dad was a fighter, right? He's a swimmer, he's a coach, and now he's saying like he can't do it anymore. He's also saying like he's declining, he's not eating as much, his body's just shutting down. And so that's the difficult part. And so when you think about hospice, we always like to talk to families and help them understand. You're going to think about three things. What does hospice focus on? Where hospice happens, and also when is hospice appropriate. So what does hospice focus on? Specifically, if someone qualifies for hospice, it's really pain management and symptom management, emotional, spiritual support, a lot of support for family as well, and honoring the patient's wishes. So they do anything. Oh, let's see. Something happened. Oh, we're good. Are we good? I think we're still on stream. Kind of pause for a second. All right. So and really just making sure that his wishes are honored, that everyone understands what he wants and what he desires. So where does hospice happen? It can happen anywhere. So it could happen at home, it could happen in a assisted living facility, it could also happen at a skilled nursing facility. So hospice is not a place; it is a benefit, and it's a group of people, a team of people to help support Danny through this season. And so a lot of families ask, can it be done at a group home? Yes, it can be done at a group home, an assisted living facility, several places as well. And so when is hospice appropriate? So hospice is appropriate based on the clinical implications of your loved one. And so a doctor will say, I think, Danny has 6 months or less to live right now with all the things that are happening to him, his weight loss, coming back and forth to the hospital, his wishes that he's staying, that he can't do this anymore, the pain, all of those things. The doctor will then state and write an order. I think it's time to consider hospice services. And so when you're thinking about hospice as a whole, there's three core areas uh, that are help families to kind of understand what it is. Hospice is it can be very convoluted, it can be difficult to understand. So we like to break it down into these three areas so that you can have a good understanding. So you're talking about care team, supplies, DME, and then medications. So let's talk about the hospice care team. So think of this team as a support system for Danny, for Lauren, because we're talking about them specifically. So the first person who's in charge, the first quarterback, if you may, is the nurse. The nurse is that nurse case manager who comes out, reviews everything that's going on with Danny, his whole history, even his career when he was a coach, all those things to get to know Danny, and then also look back over the last 6 months to a year of what's happening to him clinically. He had the stroke. He was doing home health. He was doing progressing well, but then he had a dip. Then he went to the hospital. So that nurse's job is to review all those things and also look at his wishes. What's his care plan? What does he desire? What does he like? What he doesn't like? And really set a good game plan and a care plan for Danny's time on hospice. And so that nurse will review those medications, review the medications that would be covered under hospice, and then review the ones that won't be covered under hospice. And then that nurse creates that specific care plan for Danny. Another important piece of the hospice team is the aide. So now an aide can come out. Now, the aide is not there to kind of be at the bedside 24/7 or to be there for several hours. The aide is underneath the RN and is given a hospice aide assignment or a hospice aide care plan. And the nurse will say, okay, based off of what Danny needs, I think the aide should come out 2 times a week, 3 times a week to do some bed baths or to help with bathing, some hygiene, some shaving. And it's a care plan. And that aide has to follow what the nurse says underneath the license of the nurse, because the aide is a CNA, a certified nurse assistant. And it's a big help and a big benefit for families to help because that is a difficult part, especially bathing your loved one. It is a big help. The next part is a chaplain and a social worker. So the chaplain is there. A lot of times when families see chaplain, they think of religion or pushing something on a family or loved one. But a lot of times it's their emotional support. Grief, is difficult because now Danny goes from being a coach to then retiring, then to having a stroke, then also he's probably still grieving over the loss of his wife, and all those things. The chaplain is there to kind of walk through and guide families through that emotional support. Social worker is the same as well. Social worker also has the ability to help in more detail, living will, end of life coordination, funeral home arrangements, and it kind of takes the burden or the weight of all those logistics off of the family, and you have someone who can help you logistically help. And so also the medical director, so that doctor. So now Danny's had his PCP for several years. His PCP has known Danny for a long time. Every hospice has to contract with the doctor who oversees, because these doctors are specialized in end of life care. So let's say something is going on with Danny in the middle of the night. That doctor can now triage and coordinate with the nurse to say, okay, let's go ahead and change these medications because he's not doing well. And so that's a quicker response. And that's why Medicare made that to where that hospice doctor is attending and overseeing the care of Danny. So it allows for quicker coordination. It allows for quality measures to be put in place, because these are experts that I can now guide the nurse and the care team through everything that needs to be done for Danny. So it's a beautiful help. It is a beautiful team that's there to support. And this is just a few components of the team, but one of the areas that's really helpful for families when it comes to hospice care. Next is medication. So we talked about this a little bit. When the nurse, case manager, the quarterback comes out and does the assessment, she'll look at all of his meds and look at all of his covered and non-covered meds. So what that means when I say covered or non-covered, anything that's pertaining to the hospice diagnosis will be covered underneath the hospice. And then anything that's not underneath the hospice diagnosis usually won't be. The nurse's job is to coordinate and to help the family and patient and Danny and Lauren know these are the meds that will be covered and not covered. A beautiful thing that we've seen over the years is that a lot of times there's just so many medications that are given to patients, from the oncologist, the cardiologist, the pulmonologist, the PCP, the urologist. They're all the ologists, right? And so you have all these medications. A lot of times what we see is that the best hospices, what they do is that they'll go through all the medications and reconcile them and say, all right, this medication, you may not need this one. Let's go over this one. What is this one doing? What is the goal of this one? And it's a beautiful thing, because then you can kind of discharge some medications that may not be needed, and you have an expert to walk you through that. On top of that, another great thing that happens is that now, instead of going all the way to so many different pharmacies. The best hospices, what they do is they'll coordinate all those medications and then drop ship them to the home, the group home in Danny's case, and making sure that there's a MAR, a medical record, so that everyone knows exactly what all the medications are being taken. So it's really great. And then when it comes to Danny, and as he's declining and he's maybe getting worse, he's in more severe pain, those medications can be triaged and coordinated by the nurse and the team to make sure that he's comfortable and that he can continue to maintain and enjoy his quality of life, which is a big thing. Third part, which is DME and supplies. So now Medicare is covered under Part A, which will kind of go into the insurance part. So all of the equipment that you see here in this image are covered under hospice. So a durable medical equipment is what DME is. So hospital beds, wheelchairs, walkers, supplies like incontinence material, depends, chucks, all those things that are utilized for his care, for Danny's care, are now covered. So the hospice will have like a sheet and say, hey, these are the things that we'll order, and then it'll be drop shipped or brought by the team to Danny's group home. And then that will be done every so often. Depending on the hospice, it could be weekly or every other week, or depending on the needs. It's a beautiful thing as well. And now let's say you want like a really nice walker, really expensive walker, really expensive hospital bed. Now those things are usually not covered under hospice. The hospice will have their formulary of the things that they have there because it's all covered by insurance. Anything outside of that, usually families will be like, okay, let me go buy this because I want this for my loved one. And that's okay too. You're more than welcome to do that. So those are the three areas that we talked about. So now where does Lauren start now that she's had this Hospice 101? She kind of has a little bit of understanding of what hospice is. Where do we go from here? So the first step we talked about was recognizing that it may be time. And that was kind of when Danny, her dad, was kind of talking about, I'm tired, going back and forth to the hospital. He did his bout of home health for a long time. He did great, progressed really well for home health, and met all the goals. And then it got to a point where he started to take a dip. And then the doctor wrote the order, which is step 2. And that order is hospice evaluate and treat. And now it's Lauren's job, which is a difficult job, Lauren and Danny's job, or any family members, to kind of pick the right hospice and to choose the right provider, because not every hospice every hospice is not the same. And so it's important that the family chooses or kind of gets a recommendation or finds out which hospice works for them. And then the final step is the admission and care begins, which is what we talked about. The quarterback or the nurse will be the first one to go out, kind of get all the clinical information from the hospital, from the rehabs, from everything, and then create a good care plan specifically for Danny and for Lauren. And so we talked about the qualifications. And so for hospice to be initiated, there has to be clinical qualifications. So you can see the heart, the lungs, the brain, blood, right? Debility, which is the old man with the walker, and cancers. These are all clinical implications that will qualify someone for hospice. So now, specifically for Danny and his stroke that he had, all of those things will clinically be reviewed by the hospice to see if those measures are met in order for him to actually be admitted to hospice services. Insurance. So who pays for all of this? So now Danny is now 75. So he's 75 years old. He has Medicare Part A and B. Medicare Part A will cover hospice services. Now, if Danny was younger than 65 and he didn't have Medicare and he had maybe like a commercial plan through work, now each of those insurances may have a benefit of hospice. And so what we usually tell families is that when you have someone who's younger, it's best to reach out to your insurance to see a list of hospices that are in network so that you can reach out to them and figure out which hospice would be the best. But most hospices are contracted with Medicare, and Medicare Part A is the part of Medicare that covers hospice services. And those are all the payers. So now Lauren has made the decision to start hospice, has kind of weighed all the factors, picked the best hospice that she felt was best for her and her dad to take care of him in his last days. And she felt good about that because she did the research. She took her time. She figured out who was best, and it allowed for that whole process to be a little bit smoother. It doesn't take away, like, death is hard. End of life is difficult. But what hospice is there for, it's there to help support families so that it makes that season of life just a little bit less turbulent, a little bit less hard to bear because you're not doing it by yourself now. And so now, Danny, he's at the group home on hospice. Let me see if I can switch this a little bit. Yeah. Okay. He's on hospice, and he's at the group home. He's able to get an aide. He's able to get a nurse to help at the bedside for aid services. He's got this doctor who's over the hospice to help triage, and he's able to watch, swimming. I think it was like during the Olympics last year. So it's just a great. It is a help. It doesn't stop the decline, right? And so he's continuing to decline. He's continuing to be on hospice, but it's more about quality. It's more about dignity, and it's more about comfort for him now. And it's a beautiful thing. And so we talked about this with Danny's kind of his whole life, right? So Danny had the stroke. When he had the stroke, he went to the hospital. At the hospital, he then went to the rehab for a couple weeks, and he had really strong, really intense therapy, physical therapy, occupational therapy to help with his upper extremities and range of motion, activities of daily living, which they call ADLs. And then they also had a speech therapist to help with his speech. And then when he went home, he had home health for several months, almost close to a year. Physical therapy as well, helping him at least get back to his functional goals that he had prior to his stroke. And then since he was at the group home, he didn't really need to pay out of pocket for personal care services. So that's where if he had long-term care insurance or he was a veteran, he could have get someone to be there at the bedside for a couple hours a day. Those aren't covered by your normal medical insurance. Those are covered either out of long-term care insurance, which you pay into, or he paid out of pocket for a while to be able to do those services. And so since he was at the group home, he already was paying a certain amount for him to be at the group home, and there's caregivers there at the group home. So that's why he didn't utilize personal care services. Palliative care is different. Let's say he wanted to continue to do aggressive treatment. Danny decided that he was home health and then went straight to hospice because he was done. And so he didn't go through that palliative care route. Specifically, he went straight to hospice services and got that end of life care, comfort, dignity that we were talking about, the emotional support for him, and also Lauren, specifically with Lauren being out of town. But she's been able to come back and forth a lot with him being on hospice services. So, but yeah, those are all of the options that families have when you're talking about care at home. It's home health, it's personal care, it's palliative care, it's hospice care services when you're talking about care at home. So hope that helped. We have actually JT in the back here. We're going to walk through a couple questions as we usually do. See if I can pull them in real quick. And then,
Hey, what's up?
How's
Can you
it
hear me
going?
okay? Good.
Yeah, perfect.
Awesome. Sweet. Thank you. That was great. It's Stroke Awareness Month, so
Yeah,
we wanted to bring attention to this challenge for families that, like you said, this situation that happened at 60 can happen older or younger. So
yeah,
there's definitely a lot of discussions that families need to have, specifically when you're talking about home health and that transition to hospice. What are some things, not just for stroke patients, but for home health patients that have been having physical therapy or nursing at home? Some things
Mhm.
that you gain switching to hospice and some things that you maybe lose when you
Yeah.
switch to hospice?
Yeah, and I think that's a big, great question. Is let's like in Danny's case, he was seeing his PCP for a lot. He was also getting a lot of strenuous therapy. He was getting, he would go back and forth to see his other specialists as well. So, on home health, you can continue to do that. But when you switch over to hospice, now the goal is not to continue to treat per se. That there's still a treatment that is done under hospice, but it's not going back and forth to the doctors anymore. It's not having a lot of therapy. It's really comfort, and that was voiced by him saying, he didn't want to do that anymore. Like he was like, I don't want to do that anymore, and he was able to verbalize that, which was great. And so it really switches from goals of strength, improvement on home health to now comfort, quality of life. And so you do lose some things, but you also gain a lot. So you gain a lot of help and support under hospice care, if someone does qualify. So that's a great question.
For sure. And then I know this is a hospice 101 in our lives, but if we take it back a step further, so they're not on home health yet, they're hospitalized with their first stroke and they're not
Yeah.
ready for hospice. You posted, if y'all don't follow Charles on LinkedIn, he's active on there as well, but
Mhm.
you posted this week um, the first 72 hours
Mm,
after the hospital, the purpose of home health, kind of break that down in case someone watching this is
yeah.
stroke or knows someone with this condition, but they're not ready for hospice yet.
Yeah, it's huge. I think let's go back to Danny, right? He had the stroke and it was a life-changing event, right? He went from being independent to now like needing help specifically with everything. So him going from the hospital, then going to a rehab, a lot of times that's the transition, depending on if he's not safe to go home. So the hospital discharge case manager, when they're at the hospital, the team at the hospital will review how Danny's doing and say, okay, great. PT came in at the hospital. He walked a little bit. He was, modified independent or mod assist needed or max assist needed. They have these measures and they'll say, okay, if he's max assist, he's not ready to go home by himself. So the PT will say, nope, needs rehab. OT will say, nope, needs rehab. And then in that situation, the discharge case manager will say, okay, great. Here are 4 or 5 rehabs in the area. These are the ones that will maybe accept his insurance or not. And then he transitions to the rehab. Now, let's say he wasn't mod or max assist, right? Or didn't need as much, but still needed help. Then they'll say, okay, great. He's safe to go home, but he needs to go home with home health, right? And so now that happens. He goes home, and now the home health should be there within 24 to 48 hours because it's very, very pivotal. So picking the right home health is very essential and making sure that you can reach out to them. Case managers usually have a list from the hospital that you can kind of pick, but you, Lauren, in that situation, was the daughter, should be able to say, okay, let me do my research and figure out if I can reach out to a home health so that we can get someone in there, because those first 72 hours are very pivotal. So it's not just him going home, it's getting a nurse there to get all the medications reconciled that was given at the hospital and to coordinate with his PCP, his primary care physician in the community, to make sure that a lot of times the PCPs don't even know that their patients are in the hospital because nobody alerted them. Right. So in this situation, home health is that person to be able to say, okay, great. Danny was in the hospital. He's at home now. Let's call Dr. Greg and let him know that he was in the hospital. Are you willing to help us coordinate so that we can get him back to his functional stability where he was at prior to this stroke? And so that first 72 hours is very pivotal because if those things aren't in place, it's very easy for someone to go back into the hospital because nobody's guiding them or nobody's hand holding through this process because it's a very foreign process, especially for Lauren too. So yeah, 72 is first week, 72 hours to a week is very pivotal. So
Awesome. Sweet.
great question.
Yeah. That's all we got today. So thank you all again for hopping on. You can get in touch with us, hospice.charlin.org. Either fill out a form or talk to someone on our team, about care coordination for your loved one, or call our office anytime. Home health, hospice.
Sweet. Awesome. Hey, see you guys next time. Good to see you guys. See you next week. Bye.